Okay, good morning, and thank you for attending this session. The title of my paper is up on the screen, and as so capably introduced by Professor Pilcher, I'm an intensivist from Melbourne. So, once we successfully scroll. Okay, this is a list of my co-authors, and I acknowledge their contribution and eminent expertise, in particular Johan Martinsen and Professor Belomo, who have contributed the most along with myself. So by way of background, we know that a proportion of patients require prolonged intensive care support. The literature has previously referred to this clinical syndrome as either chronic or prolonged or persistent critical illness, but it's been very variable, it's been arbitrary. The definitions have relied either on the underlying pathology, such as failure to wean from mechanical ventilation or critical illness-associated weakness, or the duration of ICU admission, be that 14 days, 28 days, or the timing of elective tracheostomy, or the need to remain in intensive care after the reason for admission has been treated and is no longer active. This clinical syndrome has an increasing burden of disease. There is disproportionate resource utilisation, with only 5% of ICU patients affected, but taking up in excess of 30% of ICU bed days and 15% of hospital bed days. And they have unfavourable discharge outcomes, with a hospital mortality of around 25% compared to ICU all-comers of less than 10%. So this has created a need for a logical, statistical and epidemiological definition, and to that end, Jack Washiner and colleagues published in Lancet Respiratory Medicine in 2016 a large observational study of over 1 million patients from Australian and New Zealand ICUs over a 15-year period, where they derived a new empirical definition of persistent critical illness, comprising an ICU length of stay greater than 10 days, and that was simply the point at which the prognosis was no longer based on the severity of illness and admission diagnosis, but rather on simple pre-ICU patient characteristics, being age, gender and chronic health status. And this is the receiver operating characteristic curve, showing a crossover point at 10 days, beyond which the pink line, the antecedent characteristics, had better predictive value for mortality. This is from Icu Mortality's paper. So this has coined a new term of persistent critical illness, or PERSI, and our study aimed to test whether PERSI is associated with a greater incidence rate and specific types of in-hospital complications. So we conducted a retrospective single-centre observational case control study where we reviewed existing databases, patient records and coding data over a 5-year period, and we ended up with 300 PERSI patients, obviously defined as a length of stay greater than 10 days, matched in a 1:3 ratio with controls who we defined as a length of stay less than 6 days, to create adequate cohort separation. And these are the 4 criteria on which we matched our cases and controls. So this is our cohort selection flowchart. You can see we started with 7,500 patients, and using aortic, we filtered it down to just over 300 cases and 5,000 controls, and we took the first 300 of those cases and matched them accordingly. The outcomes were predefined as baseline patient characteristics, process of care, outcomes and disposition, admission diagnoses categorised by organ system, and complications coded on discharge. In turn, we defined complications as ICD-10 diagnoses not present at admission. We classified them according to the classification of hospital-acquired diagnoses, known as CHADX, and we also adjusted these complications for exposure time, specifically for ICU bed days. We undertook 2 sensitivity analyses, one comparing patients admitted to ICU on the first day of their hospital admission versus those admitted on subsequent days of the hospital admission, and also PERSI patients compared to controls who survived a minimum of 10 days. And this was in recognition of the fact that persistent critical illness can only develop once you have survived a minimum of 10 days. We also undertook a nested cohort comprising an additional detailed analysis of a 10% random sample from our original dataset, where we explored the timing of complications relative to the ICU admission, their contribution to major adverse outcomes, whether these were iatrogenic, and if so, the attributable clinician. Our statistical analysis explored continuous data, it explored categorical data. We reported our complications as the number per patient with confidence intervals, and we also reported the complication rate, being per 1,000 ICU bed days. We compared the mean number of complications between cases and controls using Poisson regression, and we used a 2-sided p-value of less than 0.01. So our patient characteristics were well matched at baseline on age, gender, Apache score, mechanical ventilation, and operative versus non-operative admission diagnosis. There were, however, some differences. There were lower rates of direct ICU admission amongst PERSI patients. They had higher Charlson comorbidity scores, and they had slightly less favourable biochemistry and haematology. I won't dwell on this table, but this is the results of process of care, major complications, outcome and disposition. And you can see there on the right that there's a number of outcomes that are statistically significant, and they're shown graphically on the subsequent slides. Length of stay, 16 versus 2.3 days. Hospital length of stay, 41 versus 8. Mechanical ventilation, 260 versus 19. Not surprising given how we'd predefined our groups. This is where it starts to get a little bit interesting. ICU mortality, lower in PERSI patients, 16 versus 22%. Hospital mortality, not significantly different, p-value of 0.5. However, discharge home, 10% fewer PERSI patients were discharged directly home compared to controls, 52 versus 62%. Now, these were the 7 most common coded complications. You can see ranging from 30 to 45%. Hypotension, sepsis and septic shock, pneumonia, delirium, acute kidney injury, pressure injuries, and electrolyte disturbance. Now, major complications in multi-organ failure. Look at this. We have 6 times greater dialysis rates in PERSI patients. We have 17 times greater intubation rate, and we have a 60 times greater tracheostomy rate. Perhaps not surprising, but look at the numbers. And then looking at multi-organ failure, we have 63 versus 11% of PERSI patients with more than 8 number of affected body systems, and therefore a greater proportion of multi-organ failure. Now, this is where it starts getting really interesting, and if you take anything home from this talk, look in detail at this slide. The blue bars are the PERSI patients and the orange bars are the controls. And you can see that from hypotension onwards, all to the right, you can see the orange bars are higher for all of them. This is a slide where we adjusted complications per 1,000 intensive care bed days. And all of these complications were higher in controls. So more controls had these complications per ICU bed day than did the PERSI patients, who were the ones that stuck around longer. We think this is probably attributable to the fact that CHADX diagnosis does not code for the time of onset, severity and duration of illness. For example, if you look at acute kidney injury, you have 3 times the rate of acute kidney injury in controls, 60 versus 19%, but dialysis is not significantly different. Look at pneumonia and septic shock. You have twice the rate of pneumonia and septic shock in controls, but reintubation and tracheostomy is still higher. So even though pneumonia and septic shock have been coded, presumably the severity and duration of that illness has been significantly longer in patients who ended up with persistent critical illness. Very busy slide, I won't dwell on this, but on the left you can see these are the CHADX categories, which are essentially organ systems, and on the bottom you can see that we have our cases averaging 12 complications per stay versus 4 complications for controls with a very statistically significant p-value. This is the same table represented graphically. The blue bars are the PERSI patients, and you can see they're all higher. Everything other than accidental injuries is higher unadjusted in terms of complications by CHADX category. However, the exact opposite happens when we adjust it for length of stay. And this is remarkable because it tells us that, again, every single category has a higher complication rate in controls. So people who have stayed in ICU for a shorter period of time have more problems happen to them on any given ICU day than persistent critical illness. So there has to be something else separating these groups rather than just the things that have happened to them over their stay. In our nested cohort, the procedural complications were similar. Tracheostomy malfunction was slightly more common in PERSI patients. You can see that there is a variety of issues that were more common in PERSI patients. However, again, following adjustment for exposure time, complications rate became similar or higher in controls than in PERSI patients, and no major differences were found in the sensitivity analysis of survivors who lasted longer than 10 days. So persistent critical illness is associated with a much greater absolute number of complications, but indeed controls had nearly 3 times a greater complication rate after adjustment for their time in ICU. Persistent critical illness patients have similar hospital mortality, but fewer were discharged directly home. There's a number of complications that appear iatrogenic, perhaps procedural related or drug related. This is the first study utilising the new empirical definition of persistent critical illness to focus on the associated in-hospital complications. We used a systematic approach to defining complications, one that's not amenable to bias. We had a large cohort. We had external validity demonstrated by our mortality outcomes that were comparable to other published outcomes in other papers. We've revealed a number of insights about the mortality and in relation to the implications of complications in these patients. However, this is a single-centre study. This is retrospective with the inherent limitations of such papers. We relied on CHADX, which in turn relies on the ICD-10 diagnoses, coding accuracy and the integrity of documentation. And there is a risk of underestimating diagnoses and complications by up to 25%. And importantly, we had no information on the time of onset, severity and duration. So in conclusion, persistent critical illness prognosis is better predicted by the antecedent characteristics than by admission parameters. We now know that although persistent critical illness patients experience more complications, this is due to longer exposure time and spending longer in intensive care. We know that they experience specific types of complications, which can now become the logical focus of intervention, but requires further detailed assessment in future studies. And we now know that development of persistent critical illness is probably not a mostly iatrogenic event, but rather an expression of more severe underlying illness and possibly comorbidities and frailty, something that can be further explored using the new COMET database, which is rapidly building in quantity and quality. And persistent critical illness is really a reflection of an underlying illness that neither has a rapid resolution nor leads to early mortality, with patients essentially stuck in the grey zone. Thank you very much for listening.
Thanks for a really interesting talk on a very significant issue for all intensive care units. Two questions. One, you, I think, have taken two really quite disparate groups of patients and sort of analysed them and said they're different. And I wonder if you'd thought about whether you could have done a sort of matched analysis to see if there were other factors there rather than sort of taking two very disparate groups.
Sure. Sorry, can I get you to clarify what you mean by different groups?
So your short-stay patients, or shorter-stay patients, are quite different from your long-stay patients. And it's a bit like you've taken a study of apples and oranges and said they're different.
Well, according to our baseline patient characteristics, they were in fact very, very similar. So everything from demographics to acuity as reflected in their Apache scores, rates of mechanical ventilation, their operative, non-operative or emergency, non-emergency admission diagnoses were indeed similar with a p-value of approximately 0.5.
Yeah, I suppose what I'm saying, at a population level they're separate, but if you went down to the individuals, if you were going for a sort of a matched analysis or a intensity matched analysis, do you think that might add some value there, is my question really?
Look, it's possible. I mean, that's one of the reasons that we undertook a sensitivity analysis looking at survivors beyond 10 days, and this is survivors beyond 10 days who were initially in the first group of being discharged from ICU less than 6 days. And certainly in that sensitivity analysis, we found no significant differences to our principal findings. But there is further exploration to be done, yes, for sure.
Can I have a second? Yeah. As I've got the microphone. The other thing is I wondered if you looked at the time course of those complications that you saw. Are they predominantly front-loaded? As the patients come into the unit, they tend to be more unstable and therefore more things are being done to them. And whereas once patients have been in the unit for 10 days, they are in that grey zone, as you say, but less is being done to them, and I wonder if there's less opportunity for things to go wrong.
Look, thank you. That's a very important question. The only subgroup in our cohort for whom we have that information is the nested cohort, which is the 10% of the total of 1,200 patients. And in that group, there is certainly a mix of before, during, and after ICU admission. But the majority of these complications are not front-loaded. Certainly, things like pressure injuries, very much pressure injuries and delirium, for example, very much tend to be in or following ICU, whereas hypotension, acute kidney injury and sepsis are somewhat evenly matched between the groups. But this is one of the inherent limitations of CHADX and the coding done downstairs by the trained coders, and the fact that the ICD-10 does not reflect that particular information.
Yeah, look, I was just interested. So the mortality in the two groups was lower in the group with persistent critical illness. Is that correct?
So in our cohort it was, and it was 16 versus 22%. I guess the important thing to remember is that there is an intrinsic selection bias, because our PERSI patients are those who have survived a minimum of 10 days in intensive care. So in order to be defined as persistent critical illness patients, they have survived a minimum of 10 days, at which point they become persistent critical illness, and so we have already excluded all those who have died between 0 and 10 days.
Sure. But it's interesting, isn't it, that their discharge destination was not home. Is that correct? It was
Yeah, so only 50% of them were discharged home compared to over 60% of non-persistent critical illness patients, so lower rates of discharge directly home, presumably indicating that more of them have been discharged to either subacute facilities and or nursing homes to recuperate. And of course we know that this links in with Dale Needham's and many other eminent people's work on post-ICU syndrome and reduced level of function and the long-term consequences post-ARDS and post-multi-organ failure.
Yeah, and being due to chronic disease maybe that's pre-existing.
Yeah, and the ongoing reduced level of function related to the critical illness experienced in the ICU.
It's an interesting finding. Yeah.
Boris, thank you very much. Thank you.